To the Minister of Health, and I call Michelle Guy.
Trusts are responsible for delivering on the screening services they provide. They have a statutory duty of quality. Each trust is responsible for maintaining internal structures to support quality improvement and local coordination of screening services, and they're also charged with ensuring their workforce is appropriately trained. The Public Health Agency, it provides oversight and external quality assurance for screening programmes. It's also responsible for maintaining structures to support quality improvement and coordination of the screening programmes across Northern Ireland. Screening programmes have a learning event protocol. That protocol sets out the arrangements between the trusts and the Public Health Agency to support a culture of shared learning in order to improve the quality and the safety of the programmes. Any issue, regardless of impact, including near misses, should be reported immediately by the Trust to the relevant screening team in the PHA. They will then work collaboratively with the Trust to investigate, review and implement any actions recommended because of the investigation. For more serious incidents, or if more than one Trust is involved, an incident management team will be established with involvement from the relevant stakeholders. Serious adverse incidents are notified under the regional procedure for the reporting and following up of SAIs. Individual learning events are discussed at regular meetings between the PHA and the Trusts, and a summary of learning events is reviewed at regular regional quality assurance meetings with an emphasis on sharing lessons learned with other unaffected Trusts, identifying trends that require further investigation, and agreeing mitigating actions to reduce the chance of reoccurrence. The learning event protocols are regularly reviewed and updated accordingly.
Mrs. Guy.
Thank you, Mr. Speaker. And Minister, thank you for the answer. Was this protocol in place in the years between 2008 and 2021, considering the significant amount of women, particularly in the Southern Trust, that have been placed at considerable risk in those years? And who is accountable for the lack of adherence to this protocol?
Well, I thank the member for her interest in this issue, which I think goes much broader than a protocol. And like her, I'm no doubt she was shocked at the length of time that passed before there were the right interventions. So the screening programme encompasses a range of services provided by the Trust GPs and the Business Services Organisation. We have had a number of reports into what went wrong or the occurrences in terms of the Southern Trust. I now await some quality assurance reports, and I will then be making a decision on the way forward. But I think the point is it doesn't matter what protocols that you have in place, it's whether they are effective and whether they are followed. And clearly something went very badly wrong, and it affected a really large number of women. And I am determined that we will get to the bottom of it. The questions we must ask are, what went wrong? Why did it go wrong? Who was responsible for it going wrong? And what steps can we put in place to ensure that it never happens again, or at least to minimise the chances of it ever happening again?
Dylan.
Thank you, Mr. Speaker, and thanks to the Minister for your answers so far. Minister, just in relation to Ms Guy's question on the protocols, so are you saying that something has actually changed, something new has been implemented in terms of ensuring that PHA has that overarching responsibility to ensure that what is happening within the Trust screening programmes is being done effectively, properly, and that there are no issues? And can you also give us some reassurance around the accreditation status of the HPV screening services within the Belfast Trust that are currently in place? Because obviously, again, I would encourage every woman out there to have her screening, her smear test done, please.
Well, I join with the member in encouraging women not to be shy and not to be put off going for screening, because I think it's very important that they do so. I think the issues in terms of Belfast's accreditation I am going to characterise as more technical than real issues in terms of the quality of the screening, and I think that is being addressed. In terms of the overall picture in terms of screening, we follow the advice of the National Screening Committee. So I am satisfied that everything is being done that should be done to ensure the quality of screening operations within health and social care in Northern Ireland.
Dodds.
Mr. Speaker, Minister, I noticed that you didn't answer the last question. The Belfast Trust has been given the contract for the regional cervical screening programme for Northern Ireland, despite the fact that it is not yet accredited for such screening. Are you satisfied with the decision to award the contract to the Belfast Trust, which in a recent committee meeting in Daisy Hill, the PHA admitted that they were short-staffed and were having to send tests to Gateshead in Newcastle in order to clear a backlog of screening? And in awarding the contract in this way, you bypassed two trusts, the Northern and Western Trust, which were fully accredited, and the award of that contract resulted in the resignation of two senior members of the service.
Minister.
Well, I thank the member for her remarks. What I would say to her is I do believe that the awarding of the contract was the appropriate, the best way to go forward. I do accept that there have been issues with workforce. There's also been an issue with some equipment. But as I said in my previous answer, I think any issues with accreditation are more about technical and administrative issues than with the quality of what is being done. It is, of course, a matter of regret that some of the tests had to be exported to get the results expedited. But I think we are moving in the right direction with regard to providing that screening.
Thank you, Mr. Speaker, and thank the Minister for the answers so far. Minister, can we absolutely tie this down and clarify? Can the Minister advise who is ultimately responsible for the policy decisions in relation to the screening programme?
And I thank my colleague for his question. The Department is guided, as I've said, by the UK National Screening Committee. It's an independent committee. It advises ministers and health services across the 4 UK countries, and that's about all aspects of screening. Its recommendations are evidence-based, and that's about whether to introduce, continue, change, or withdraw screening programmes for a variety of conditions. In addition, there's a Northern Ireland Screening Committee, and it considers recommendations from the UK National Screening Committee. It's chaired by the Chief Medical Officer. The Northern Ireland Committee provides policy advice to me, and there's a specific focus on implementation issues here in Northern Ireland. I then consider and make my decision regarding screening policy in Northern Ireland, and that's based on the advice, as I said, of the UK National Screening Committee and indeed the Northern Ireland Committee.
Durgan.
Speaker. Minister, with regard to bowel cancer screening, we still lag behind the other regions of the UK in terms of the age range for screening. How and when will we see this disparity addressed?
Minister.
Well, I have been talking with officials with a view towards expanding it, and that is part of the 3-year plan that I published recently. But it is incumbent, or it is dependent, I should say, on budget, on finance, and also on workforce. I would like to see it offered from age 50 upwards, and that is an ambition that I will work towards within the confines of budget and workforce.
Dr. Steve Aiken.
Question number 2, please, Minister.
The draft budget allocation does not align with the draft programme for government, as it provides no additional funding for waiting list reductions. Despite waiting lists supposing having been identified as an executive-wide priority, indeed, the draft programme for government states, and I quote, "It will not be possible to reduce our lengthy waiting lists within the funding currently available," end quote. And that's despite the fact waiting lists is one of the 9 priorities in that draft document. This will be the second consecutive year where no such money has been provided by the Executive. Overall, my department's proposed allocation for financial year 25-26 represents a small increase in funding compared to 24-25. However, it will not be sufficient to cover the significant increases in costs that we'll face, and that's due to a number of factors, including pay and price inflation, the increase in national insurance contributions for GPs, pharmacists and social care providers, and of course, rising demand. So as a result, my department is projecting a funding gap of some 400 million for financial year 25-26, with the HSC system asked to deliver in the region of 200 million in new savings, and that's for the second year running. Even then, it's anticipated significant in-year monitoring round allocations will be required to achieve break-even. The assumption that savings on this scale are achievable is not without considerable risk. It will inevitably have consequences for service delivery, including waiting times. With this draft budget allocation, I would challenge the Assembly and the Executive to honestly consider how they can expect us to achieve a reduction in waiting lists.
Dr. Reagan.
Thank you. And I thank the Minister for his response, for indeed nailing the myth that promoted by some that a vague reference in the programme for government is somehow an illustration of prioritisation. Does the Minister agree with me that it's the height of hypocrisy for some MLAs in this chamber to demand additional investment in existing services at the same time as actively supporting a budget that doesn't give you the resources that you need?
Well, I thank the member for his supplementary question, and yes, I do agree that there is an irony in the fact members voting for a budget despite being warned of its potential impact on healthcare delivery, and then almost on a daily basis writing to me and requesting that I consider additional funding for a new service here, a new service there, for example, bowel cancer screening. The cross-border initiative is one that at least one member a week writes to me about. It was very successful. It was so successful we wanted to do it again, and in fact it was part of a £135 million bid on waiting lists that was submitted to the Department of Finance, but was not supported by the Executive. And from memory, I think that means around 4,000 people failed to get procedures from that cross-border initiative. So yes, the irony klaxon sounds on a daily basis in the Department of Health.
Orlea Flynn.
Yes, so I take into account, of course, in terms of additional funding requirements, you're completely constrained and you're finding it very difficult to take on board any new projects or expand funding. But in terms of this current budget and your funding for core grant funding, can you elaborate on the position of how that's looking for this financial year? Because again, some groups have been in contact who were already in receipt of core grant funding. The Samaritans and CARES NI are just two examples. So where's that sitting in this financial year with the budget that you have? Thanks.
Minister.
Yeah, I thank the member for interest in the core grant scheme. When I took up position, the core grant scheme effectively did not exist in that there was no money allocated to it. I wasn't happy with that position, and in negotiations with the Permanent Secretary and others, we identified £1.8 million which should go towards the core grant. That's about 50% of what I would have liked it to have been. The other issue I had with the core grant scheme is that it had not been reviewed for over 20 years, and it meant that any new community or voluntary sector group that had come into existence in the last 20 years was precluded from applying for the core grant. So I spoke to NICVA, the Northern Ireland Council for Voluntary Action. They very kindly agreed to chair a co-design process. So we now have a new core grant scheme, and we have just allocated the £1.8 million, and those in receipt have had their letters, and those who have been unsuccessful have been offered feedback, and I intend to open up the next tranche of core grant funding in the autumn.
Andrew McMurray.
And thank the Minister for the answers thus far. Could the Minister take this opportunity to outline his priorities for the Department over the next year, and specifically priorities within the 2025-26 budget allocations?
I thank the member for his question. I've already published a 3-year plan which covers my intentions and my ambitions over the remainder of this mandate. We will shortly be following that up with a more detailed and costed plan for financial year 25-26.
Mr. Speaker, Minister, I acknowledge and have sympathy with some of the arguments you're making around hypocrisy from other executive parties, but would it be easier to get political support and buy-in and indeed public engagement on your budgetary needs if the programme for government was more specific about actions you intend to take? To compare it to the Southern programme for government, which I'm not endorsing or saying it's deliverable, it says the government will further reduce waiting times, targeting the Sláinte care target of 10 and 12 weeks, increase capacity between 4,000 and 4,500 new inpatient beds, increase ICU bed capacity by a further 100 beds. Now, I'm not saying those are the right or wrong targets, but what I am saying is they're clear and they're able to be held accountable with the Minister and the government more generally. Would it be helpful for you in terms of building political support if the programme for government had that level of detail?
I want to thank the Leader of the Opposition for the comments. I'm more focused on the three-year plan, and I don't see what's wrong with reading the three-year plan and seeing that I have targeted 46,000 additional appointments and 11,000 procedures between now and 2027.
Ferguson.
Mr. Speaker, question number 3.
Minister.
Oncology and surgical teams who manage cancer patients strive to minimise the need for emergency department visits. Every hospital trust in Northern Ireland has a 24-hour systemic anti-cancer therapy or SACT telephone advice service. Patients are encouraged to contact their treating unit using this service if they feel unwell during or within 6 weeks of completing SACT treatment or within 12 months of completing immunotherapy treatment. Similarly, cancer patients who have undergone recent surgical treatment receive verbal and written discharge advice, including instructions on how to access the surgical team and under what circumstances they may need to seek emergency care. When a cancer patient is referred to the emergency department by their GP, they'll be triaged, stabilised and assessed by the ED team, and that will be based on clinical priority within the physical and staffing constraints of the emergency department. If necessary, the ED team will contact the relevant oncology or surgical team to assess and admit that patient. In addition, each trust has an acute oncology service that aims to provide a coordinated approach to the care of cancer patients who are suspected of having a first diagnosis in the emergency setting, or indeed those admitted acutely ill due to the disease itself or to treatment complications. And currently, this service operates on a 5-day 9-to-5 model across all trusts. Extending the acute oncology service to 7 days working is a recommendation for the Northern Ireland Cancer Strategy. However, it has not been progressed due to budgetary constraints. Work is, however, still progressing to assess demand and to develop appropriate pathways, with costed proposals for extending the service being considered based, again, on available funding.
Mrs. Ferguson.
Can I thank the Minister for your answer thus far? Minister, I have a number of individuals, particularly elderly, who are terminally ill with cancer, who are still being referred by their GP to emergency department. And I've also numerous cases which I have forwarded to the Western Trust where they have had to lie on chairs for up to 5 days before they're treated. Would you agree with me that urgent action needs to be taken, particularly cancer patients who have a suppressed immune system that need priority status, and we need to look at other options so they're not lying in A&E for sometimes days? Thank you.
I absolutely agree with the member. After Christmas, I visited 7 EDs, including Altnagelvin, which, as the member knows, is the oldest of our Type 1 EDs. It is more than ready for a replacement, and one I hope will be in place, although it will be perhaps 5 years before we get to that point. When I was up in the ED, I was speaking to people who had been in the same chair for 4 days. It's not acceptable under any conditions. I also met a man who has since passed away, sadly, who had cancer, who was on a trolley, had been on a trolley for a number of days, and I think made a hospital bed for his last 24 or 48 hours on this earth. So in terms of GPs referring, I know that the Cancer Network has developed a resource for GPs to try and assist in managing mild to moderate side effects, but I think what you're talking about is a much more serious condition. And I can just assure the member that I am aware that more work needs to be done in this area, and it will be done.
Stuart Dixon.
Thank you, Minister, for your answers so far. Minister, can you tell us what plans you have to expand the vague symptoms pathway to rapid diagnostic centres, and do you intend to expand those beyond White Abbey and Dungannon?
Sure.
Well, I thank the member for his interest in this area. I have visited this rapid diagnostic centre in Dungannon. I think it's a first-class service. I was assured that if you present with one of these vague symptoms, that you will be checked in, you will be assessed, you will have your scan, and within 2 hours you will get your result, hopefully one that is pleasing and agreeable to you. I have no particular plans for for expanding the service. Because, as I've already said, members are standing up saying, do more here, do more there, expand this, introduce that. Where's the money? Show me the money and I will do it.
Justin McNulty.
Minister, for your answers thus far. Minister, it's my understanding that patients diagnosed with cancer in emergency departments have a significantly lower chance of survival than those with a referral. Minister. How are you going to address this sad reality, Minister?
Minister.
Well, I think it is a fact that people who visit emergency departments are not in a good place, and the longer they stay, the greater the risk to their health. And I think there are solid statistics for that. I'm not aware of the exact statistics that the member is mentioning with regard to cancer, but the general point is made, it is accepted, and I don't think it is acceptable that people have long waits in emergency departments, and I can just assure the member that I'm not the only one in charge of delivering health care who isn't focused on that and trying to find solutions.
Owen Tennyson. Speaker. Minister.
I recognise arrangements for clinical negligence indemnity are a matter of concern for GPs locally. My department has been exploring options for a long-term future for GP indemnity. I recognise the pace of progress in this work has taken longer than expected. However, I think in fairness that reflects the complexity of this issue. I'd committed to this work would conclude with proposals for a long-term solution by the end of calendar year 2024. I'm pleased to advise, after careful consideration of a wide range of options, I've identified what I believe is the best, most appropriate option to address this key issue for the longer term. So as part of the 2025-26 contract negotiations, my department has met with the Northern Ireland General Practice Committee. We've provided details of the long-term proposal. I'm hopeful we'll soon be able to reach agreement on this important matter. I'm aware representatives of that committee have briefed the Health Committee in relation to the offer of indemnity, and as this is still the subject of an ongoing negotiation, I don't think it would be appropriate to comment on the detail of those discussions.
Mr. Tennyson.
Thank you, Mr. Speaker, and I thank the Minister for that update, though I suspect, given the end of his answer, he's not going to answer this next question. Can I ask the Minister, what is the rationale for excluding locum and sessional GPs from the proposed indemnity scheme? And is it not the case that by excluding those GPs, those costs will be passed on to practices and therefore undermine the stabilising effect of any scheme?
It's my understanding that we are negotiating with practices rather than with individual GPs. And I do want to be careful in terms of what I'm saying, because we're not over the line, and it is an issue which, in my assessment, down the last number of years has actually become quite toxic and is affecting the relationship between the department and primary care. And there are other issues within primary care that we want primary care to address, and primarily that is access. And I'm sure every member of this House, as a constituency MLA, on a weekly, if not on a daily basis, has constituents coming to them with issues with regard to accessing their GPs. So with respect to the member, I don't want to go any further, because these negotiations are not over the line, and in my mind, the question of indemnity maybe opens up another discussion about access to primary care.
Philip McGuigan.
I thank the Minister for his response, and I take on board his caution, given negotiations are still ongoing. He mentioned just in finalising his answer to Mr. Tennyson about opening up access. I mean, can I ask the Minister, would he agree that resolving the indemnity issue would actually be very positive in terms of opening up access to greater GP services?
Minister.
That is exactly the point, Mr. Speaker, that I'm trying to make. I think if we can deal with this, as I am describing it, as basically a fairly toxic issue of GP indemnity, if we can get a long-term solution in place, then I think it gives me, as it were, permission to go back and say, well, can we now look at an issue that is very toxic for me and for members of this House, which is constituents finding it difficult to get access to to their GP.
Alan Chambers.
Thanks, Speaker. Minister, I very much welcome the fact that an offer and longer-term potential solution has been identified. If agreed, I hope that will allow even greater focus on how primary care can undoubtedly assist with the Minister's shift left agenda. Does the Minister agree that primary care has the potential to play an even greater role in addressing some of the many elective challenges being faced within secondary care? Thank you.
Well, I thank the member. I think I've made clear that my ambition is to rebalance how HSE services are delivered, and that's to facilitate a greater proportion of care to be provided by primary and community care, and indeed by social care, getting it as close to people's homes as possible, and relieving some of the pressure on secondary care. Now, I know this is going to require a combination of investment in core GMS through the GP contract, as well as investment in wider primary care services and workforce. I think when I first talked about shifting left, there was a concern amongst doctors and people working particularly in primary care that I was going to be asking them to do more for the same money. That is not the case. I recognise that if we're going to ask them to do more, we have to pay them and commission them to do more. And I think the challenge is how you get away from the pressures on our acute hospitals outright, because that's where all the really expensive procedures take place. So if you can put a focus on prevention and early intervention, maybe you will relieve a bit of the pressure on the acute hospitals and then relieve some cash which can be put into primary care.
Your question 5, please.
My department is committed to ensuring equitable and timely access to cancer diagnosis and treatment for all residents in Northern Ireland, regardless of location. It's important to understand whether individuals in rural areas face different challenges or barriers compared to those in urban areas when it comes to a cancer diagnosis. We have to understand any differences. Therefore, my department has funded the Northern Ireland Cancer Registry at Queen's to develop a Routes to Diagnosis research project. That project aims to identify the key event in each cancer patient's pathway that most directly led to their cancer diagnosis, whether that's through GP red flag referral, through screening programs, through emergency departments, or any other route. The report also examines cancer stage at diagnosis by route diagnosed. This research will highlight any demographic inequalities in diagnostic route that will need to be addressed. Identifying and addressing these disparities will be essential for promoting early cancer detection, for improving survival rates and reducing cancer mortality for all. The most recent report, published in 2024, provides findings for patients diagnosed in the period 2018 to 20. It includes analysis by demographic characteristics such as age, sex, trust area and social deprivation. The Northern Ireland Cancer Registry are now working on a follow-up report for patients diagnosed between 2018 and 21, which will provide analysis on cancer patients' routes to diagnosis, analysis by rural and urban location.
Mr. Donnelly.
Mr. Speaker, and I know the Minister recently attended the excellent Rural Farming Network and Macmillan Nip It in the Bud event in the Long Gallery. He'll be aware that people in rural areas, when they have advanced cancer diagnosis, are 5% less likely to survive than people in urban areas, which obviously is completely unacceptable. I appreciate his answer about routes to diagnosis. I'm wondering what else he's doing to reduce the barriers to cancer care in farming in rural areas.
Well, Mr. Speaker, will take a broader run at answering the member's question. He'll be aware that health inequalities is the area where I want to put a real focus in my remaining time as Minister, and I think health inequalities is almost a shorthand for three things: inequalities as in outcomes, but also health inequities as in access to health care, and thirdly, health literacy, because unlike members of this House, there would be areas, particularly in areas of deprivation, where people don't know how to navigate around the health and social care system in the way that we might. So I think the rural challenges are greater than the urban challenges, because in terms of tackling, for example, health inequalities, the Live Better initiative, which is now in 2 demonstration areas, have deliberately been chosen as very tight urban areas so that we can collect the empirical evidence, which will be much harder to do over a rural geographic spread. That does not mean we're going to ignore the rural areas. It just means I need to be able to go back to my executive colleagues and say, here is really solid empirical evidence that these interventions work. Now we're going to face the challenge of how we make them work in the more challenging area of rural, and that will include cancer diagnosis and cancer treatment.
Moving to topicals, Colin McGrath.
Mr. Speaker, Minister, in the media today we have learned that Alfie Pentony, a 12-year-old from Newry who suffers from Duchenne, a rare form of muscular dystrophy, is being deprived a new drug which could delay the onset of muscle wastage, resulting in him being wheelchair-bound for the rest of his life. Once such muscle wastage commences, he would be unable to avail of the drug, and therefore timing is critical. Minister, the new drug has been approved by NICE and is available via an early access programme in other parts of the UK, but it is not available here in Northern Ireland. Is it fair that Alfie and others who have contacted our constituency offices are being deprived access to such drugs?
Minister.
It would be my ambition that it would be a UK-wide facility which would bring on any drug, and NICE and the Medicines Regulatory Body will give us advice, and that's the advice we follow. I think in this instance it is my understanding that it is the Belfast Trust who can decide, who make the decision about whether this young man is allowed that drug or not. I am following up with the Belfast Trust to further understand their decision-making process. Several members have approached me about this new drug for their constituents. On the face of it, and I'm not a clinician, it looks like it is a revolutionary and very positive development. And I would be keen to see it rolled out at pace, particularly for a young man like the one you reference.
Mr. McGrath.
Thank you very much, Mr. Speaker. Again, can I reiterate the point about at pace, because timing is critical. If they don't get access to the drug before the start of the muscle wastage, then it means the drug is of no use to them. And the word that was used by Alfie today is that not getting access to that is cruel. That's the words of a 12-year-old to members of this Assembly. It's cruel. I hope that we can overcome and ensure that he is able to get access to those drugs along with others.
I will assure the member that I'm on that case. It is a matter of coincidence, I believe, that one of the very, very first events I went to in this building after being elected for the first time in 2011 was organised by actually my predecessor as Minister of Health, Robin Swan. It was a constituency event about Duchenne's. And so it's been on my radar for a long time. I'm now aware that this new drug is becoming available, and I don't want to see it restricted from young men. And this young man will lose the power to walk, I understand, in relatively short order if we don't do something.
John Bunting.
Mr. Speaker, yesterday the Minister and I attended an event in the Long Gallery that outlined that 1 in 10 people in Northern Ireland have hemochromatosis, and that doesn't include those who carry the disease. Typically, symptoms start to appear when people are in their 40s, and early diagnosis could have significant impact on the onset of chronic diseases and also on costs related to treating those conditions once they materialise. Could I ask then, what consideration has the Minister given to ruling out early screening for this disease?
Well, I thank the member for her question, and I did find it most interesting to attend that event yesterday in the Long Gallery. I will attempt to answer a question by referring to the Rare Diseases Action Plan, because this is just one of many rare diseases. And I think what the point that I was trying to make in my remarks yesterday were, although we may call rare diseases which rarely affect people, in fact, in the totality of rare diseases, we're talking in Northern Ireland 110,000 people. Well over 100,000 people who, one way or another, are being affected by a rare disease. So let's not consider rare disease something that only affects a handful of people. And on that basis, my department recently published the Year 2 Progress Report for the Northern Ireland Rare Diseases Action Plan. That was back in September. It details good progress, including additional genome sequencing of people living with a rare condition who do not yet have a diagnosis, progression of rare disease care pathways for several paediatric and adult services, and success in a number of important bid applications to external research organisations to progress the Rare Disease Information Hub and clinical trials. And, Mr. Speaker, I will say to the member, I will go from this House, and I will ensure that in terms of pathways, that we are looking at a pathway for this condition.
Ms. Bunting.
Thank you, Mr. Speaker, and I'm grateful to the Minister for that. I appreciate it was only yesterday and I have no intention to bounce him. But just on a further issue with regard to those who have already been diagnosed, could I ask the Minister what steps he will take to ensure consistency across trusts with regard to timely and appropriate treatment and appointments for those with this condition?
Well, again, Mr. Speaker, I want to answer that question with a generalisation, which is that although we have 5 geographic health trusts, it is my ambition that those 5 trusts will deliver standardised regional services, consistent services, no matter what the condition or what the issue that they are addressing. And one of the challenges that I have put to the chairs and the chief execs of the trusts is find where best practice exists in terms of treating any particular condition and roll it out and make it common practice across the trusts. I think the logic of it is compelling, and I have yet 9 months in to fully understand the barriers and the obstacles to this happening, but those barriers and obstacles clearly exist because we still have what would be commonly referred to as postcode lotteries, and we have to stop that. We have to have health equity. Everybody has to be able to get best practice service when they need it.
William Irwin.
Thank you, Mr. Speaker, and can I thank the Minister for his answer so far. The Minister mentioned the cross-border healthcare scheme earlier, and we are all aware of how successful that scheme was. Is the reopening of the cross-border healthcare scheme a priority for the Minister?
It would be if I had the funding, but I gently remind the member of what I said earlier. We made a bid of £135 million to tackle our waiting lists. That included a significant sum of money to treat again, the figure of 4,000 patients springs to mind. I would love to be able to do it. It was very popular, it was very successful, it made sense, it took a big chunk out of a number of waiting lists. So what was not to like about it? But unfortunately, all budgets are constrained, all budgets are limited, and I cannot make it a priority when I have a £400 million gap in my projected spend according to the draft budget for 25-26. My 2 priorities, frankly, are to avoid having to make any cuts which fall into the category of catastrophic, such as closing an intensive care unit bed in an acute hospital, avoiding catastrophic cuts, and also avoiding industrial action by staff.
Mr. Irwin.
I thank the Minister for his response. Does the Minister know the approximate cost of this cross-border scheme and the potential cost of it? Does the Minister know the potential cost?
Well, the potential cost of a cross-border scheme would depend on what procedures we were commissioning and the number of people we were commissioning it for, so there is no set figure.
Well, McGuigan.
Minister, as I mentioned to you last week during the committee, that engagements I've been having recently with the Royal College of Nursing, they're expressing concern about increasing levels of fear amongst nursing staff and nursing students about the issue of violence and aggression against health and social care staff. Can I ask, Minister, for your assessment of this and if you have any updated figures on the issue?
Well, I thank the member and I share his concern. I'm afraid these things are societal issues, but it is a matter of utter regret that they are making their way onto health and social care campuses. It's also a matter of regret that they are happening to health and social care staff beyond the curtilage of hospitals and other health and social care sites. I can advise the member that this was an issue which was first addressed at some depth in recent times towards 2023 when the trusts and the union side came together and agreed a paper on violence and aggression in the workplace within NHS settings. I think that what is helpful is the pilot scheme which is happening, I think, in the Belfast Trust at the moment with regard to body-worn video. Certainly as a member of the policing board, I was very impressed with the impact of body-worn video by police officers in the PSNI. I would like to see that pilot successfully concluded and rolled out. We must have zero tolerance of attacks and we must be imaginative and we must be generous in terms of what we do to protect our HSC staff.
All right. Philip McGuigan.
And appreciate the answer the Minister gave. And I think it was a 4 to 5 year period up to 2023. There were 50,000 reported incidents against healthcare staff. So it would be interesting to know what the figure has been since then. You'll also be aware, Minister, your department launched in 2023 a new regional framework to address this issue. So it would be useful to get your assessment if that framework has been implemented and your assessment of that going beyond what you've said about body-worn.
Minister. Yeah, Mr. Speaker, I'm more than happy to provide the up-to-date figures for the member and my assessment of whether we're moving in the right direction and what more, if anything, could be done to protect our staff.
All right, Harvey.
Thank you, Mr. Speaker. How will the Minister seek to address the inequalities that exist in access to diabetes technology in Northern Ireland to help eliminate postcode lotteries to ensure fair and equitable consideration of prescribing based on need, regardless of social and economic circumstances?
Minister.
Well, I thank the member for his interest in this important issue, and what I would assure him is that the Strategic Planning and Performance Group are looking at this, and indeed one of the big issues, of course, is hybrid closed loop systems for managing blood glucose levels in type 1 diabetes, and the SPPG will be bringing forward to me their recommendations for future strategy.
Mr. Harvey.
Thank you, Minister, for your response. Currently, the transition for young adults suffering with diabetes from paediatric to adult care can result in a reduction of funding and choice of treatment. How will you address these inconsistencies and ensure safe transition for young diabetics leaving paediatric care? Thank you.
I thank the member for his follow-up. I don't have a specific answer to him on that transition, but I would assure him, Mr. Speaker, that the question of transitioning to adulthood across a number of healthcare services is far from good enough, in my opinion. It's an issue that has exercised me since taking up post. Think about, for example, ADHD. We think about autism. There are a lot of children with learning disabilities. There tends to be what is commonly known as a cliff edge when you're transitioning into adulthood, and that should not be the case. It has been the case, however, for some time, and I think it's time to say enough is enough and we need to address it. And I thank the member for alerting me that would also include the issue of diabetes, and that is now on my radar, and I thank him.
Brian Kingston.
Thank you, Mr. Speaker. And I wish to return to the issue of the unacceptable length of waiting lists for paediatric PEG surgeries in Northern Ireland. And I wish to ask the Minister what measures have been taken over the past year to reduce that waiting list, and has a measurable improvement been made?
Well, I thank the member. I think there have been a number of initiatives. First of all, consultants have been validating the waiting list. Secondly, I think there have been more procedures being carried out by the Royal Belfast Hospital for Sick Children, which is the regional centre for these PEG procedures. There has also been training going on, I believe, from the Royal Belfast Hospital for Sick Children to try and facilitate these procedures taking place at the Ulster Hospital, and that involves, of course, training of staff to make the workforce appropriately trained and motivated. So there has been some significant effort to try and address the waiting lists. I am not going to try and deceive the member. The waiting lists are still too long.
Mr. Kingston.
Thank the Minister for his answer and for those steps that have been made. Can he advise, when does he think Northern Ireland can align with NHS England standards where the newly added children to the waiting list are operated within 4 to 6 months?
Well, the member may be aware that the Independent Fiscal Council made clear that for us to deliver services in health and social care on a par with England, it would require our budget to go up to £104 to £107 for every £100 that is spent by NHS England. And in fact, the Appleby report said if you include social care, you'll need £109 for every £100 spent by NHS England. So that's the comparator to get to where I believe the member is asking me, where he wants NHS Northern Ireland, as it were, to get to. And frankly, the draft budget for next year puts us at £101 and 5p, so it's not going to be possible to achieve what the member wants.
To a conclusion, questions to the Minister of Health. We return now to the second stage of the budget bill. The next speaker is Sinead McLaughlin. Call Ms McLaughlin.